Hello, and welcome to the ACR Journals on Air podcast. I'm your guest host, Bharat Kumar, filling in for Vicky Shamagan. Chances are that when you think of the diseases that rheumatologists treat, the first condition that will come up is rheumatoid arthritis. If it's not the first, it's probably in the top 5. Regardless, RA is a condition that we've become very familiar with. Yet, about 20% of patients, that is 1 out of 5, cycle through multiple therapies without sustained relief of their pain and inflammation. Today, we'll be talking about how to identify these patients. We're reviewing a manuscript appropriately entitled Development and External Validation of a Multivariable Predictive Model for Progression to Difficult to Treat Rheumatoid Arthritis in Biologic Experienced Patients. It was published in Arthritis Care in Research, and a link to the manuscript and disclosures are in our show notes for today. We are very grateful to be joined by the first author of the study, Dr. Misty Paudel. Misty Paudel, PhD, MPH, is an epidemiologist and quantitative methodologist at Brigham and Women's Hospital and assistant professor of medicine at Harvard Medical School. Dr. Paudel is a member of the Verity Methodology Core, which provides biostatistical and methodological support to trainees and early investigators in the BWH Division of Rheumatology and the broader rheumatological research community, and a co-investigator for the Brigham and Women's Hospital Rheumatoid Arthritis Sequential Study, BRASS. You'll hear more about that in a moment. Prior to joining BWH, Dr. Paudel spent years of her professional career in a combination of academic, not-for-profit, and for-profit organizations, gaining research expertise across multiple therapeutic areas and methods. Dr. Paudel's research at the Brigham is on the epidemiology of difficult-to-treat rheumatoid arthritis and clinical risk prediction models. So, welcome, Dr. Paudel.
Thank you. It's an honor to be here.
Absolutely. So let's start off with talking about rheumatoid arthritis. For many people, it's on a long list of hard-to-pronounce chronic diseases, somewhere between rhinosinusitis and sarcoidosis. But to us rheumatologists, it's exceptionally important. Why should the general population at large take note of RA?
I think it's because it has such an impact on patients' lives in terms of the pain and the disability and just how it can overall affect their functional status throughout their lives. And we're fortunate in recent times to have many more treatment options than we ever used to have in the past. But despite all of those treatment options, there's still a not small subset of patients that are failing to respond and needing to cycle through multiple therapies. I think that's an important issue that can also have ramifications and applications in a lot of other disease areas as well.
Absolutely. And as you mentioned, it's not a small subset. But in general, rheumatoid arthritis is not a small subset of the U.S. population either. It's about 1.3 million adults in the United States are estimated to have rheumatoid arthritis. So that's about 0.3 to 1% of people worldwide. And so if you take that subset and then take a large subset of that has the cycling of different medications, you see what a big issue is. Now, let's get into your investigation just a little bit. So your investigation in general, it looked at a subset of these RA patients who have D2T-RA. And the first time I read it, it sounded like a droid from Star Wars. Clearly it isn't. And I'm not a Star Wars fan, so this was just my first thoughts. But what is D2T-RA and how often do we encounter it?
Okay, that is going to stick with me every time I see this term. Now I'm going to think of Star Wars.
Yes.
I love it. It's difficult to treat RA is what it stands for, and it's a phenotype. It's representative of a patient with RA that meets 3 specific criteria that EULAR proposed a few years ago. They have to have failed at least 2 different classes of biologic therapies. They have to have evidence of persistent disease activity, and there's a lot of different criteria that can be used to assess that. And there has to be a perception of a problem either by the patient and or by the rheumatologist. So I think the phenotype is important because it's not just cycling through meds. It's cycling through meds and not doing well.
And as far as I understand, this is that 20%, that 1 in 5 of patients, right?
Yeah, the literature has a pretty broad prevalence that it cites. I've seen as low as 5% and as high as 30%. That really has to deal with what population of RA patients they're honing in on. Are they already biologic experienced? Are a lot of them very newly diagnosed? That's why it varies. The truth seems to be somewhere between 15 and 20%.
Yeah, so certainly in our rheumatology clinics, we are seeing these D2T RA patients pretty significantly. And it sounds like they're occupying a lot of our cognitive space too, because these are patients that require a lot of consideration, a lot of mind space we should think about. Okay, so we're going to delve a little bit more into your paper. So D2TRA is not the only abbreviation in the acronym in your paper. Can you help clarify some of these abbreviations? I'm going to go through the list real quick. One of them we've already heard before, and that's BRASS. So, what's BRASS, and especially in relation to your paper?
So, BRASS is a cohort study. The longer name is Brigham and Women's Rheumatoid Arthritis Sequential Study. That is a local registry that we have here at Brigham and Women's Hospital in Boston. Enrollment started for patients with RA back, I think, around 2002 and ended maybe in 2019. Follow up was through 2023, may have even been a little bit later, but 15 years or so of potential follow up for these patients. They enrolled 1,500. They met with a rheumatologist annually and every 6 months completed questionnaires and check ins for the study. The reason why I used BRASS as my cohort to train a predictive model is because it's rich in data sources. They've got a lot of measures of clinical measures, treatments, patient reported outcomes, labs, and it's very diverse. So, about 2/3 of the patients are seropositive, and there's a nice mix of early and established RA, which makes it a really good model to train on, and then you can validate in other subsets.
And I think this presages the next acronym that's there, and that's CERTAIN.
Yes.
So, can you tell us about CERTAIN and how it relates to your investigation?
So, CERTAIN is another cohort study that I used as an external validation set. And the longer name for that study is Comparative Effectiveness Registry to Study Therapies for Arthritis and Inflammatory Conditions. This was a subset of the larger multi-center registry I think most people know of as CoreVitas, formerly Corona. They enrolled patients with RA who had moderate disease activity. So they had a CDI measure greater than 10. And they were either starting or switching to a new biologic agent. They had follow-up visits for 12 months, so a much shorter time frame than BRASS, with visits every 3 months. And then if the patient switched or needed to change their treatment, they could re-enroll in the study and time would start again. This one has a nice mix of biologic naive and experienced patients, but they are a subset of the BRASS cohort in that they are a very specific subset of patients that are generally more further along in their disease course.
And, there are, of course, a lot more abbreviations and acronyms. These ones may be a little bit more familiar to practicing rheumatologists. One you actually used a little bit earlier, but CDI? Tell us about CDI just a little bit.
Yes, CDI stands for Clinical Disease Activity Index. It's a pretty commonly used disease activity composite measure for RA. Has a lot of overlap with DES 28 is what a lot of other people know of. It contains information on the number of swollen joints, number of tender joints, a patient global and a provider global scale. And then values over 10 are considered moderate activity. There are other cut points as well.
And you mentioned another scale, DAS 28.
Yep, disease activity score in 28 joints. Another composite measure of disease activity. It has a lot of overlap with CDI in that it also looks at the number of tender and swollen joints, patient global assessment, and then it has a lab component. We use the version in our paper that has CRP, but there's another alternative one with ESR.
And there are, of course, other overlapping
Mhm.
scales as well, right? So RAPID 3.
Yes, routine assessment of patient index data 3. So a measure of RA severity. It's got subcomponents of pain, function, and global assessment, and then standardized cut points. So anything greater than like a 6.1 would be considered moderate to high disease activity on that scale.
And you also have MD hack.
MD hack. Starting to think I probably should have had an abbreviation section in my manuscript. It's multidimensional health assessment questionnaire. It's a series of patient-reported outcomes that ask about pain, function, global estimate of status. I was lucky that both of the cohorts used this particular scale, so that made it possible to do a training and a validation.
And you'd mentioned this a little bit earlier, not in its acronym form, but PROs.
Patient-reported outcomes. So like I just said with MD hack, those are our patient assessments of the pain, fatigue, function, and then the disease activity, the patient global scores.
And there are a lot of other abbreviations there. But the last one that I wanted to talk about very briefly is tripod or tripod plus AI.
Yeah, so that's a transparent reporting of a multivariable prediction model for individual prognosis or diagnosis. It's the minimal reporting recommendations or standards for studies that are developing or evaluating a prediction model. They provide a checklist of some of the best practices that, each manuscript should present, ranging everything from how the model was constructed to what you're presenting for information on it. So I made sure I was compliant with that.
Lovely. So I'm glad that we've gone over most of the abbreviations and acronyms. It'll help us certainly as we trudge through a very methodologically dense paper. And I'm glad that you told us about these two data sets that you used, which are BRASS and CERTAIN. Can you tell us how you developed this model exactly? Obviously, it is very complicated. I'm not an epidemiologist by any stretch. So if you can explain it to me in more simple terms, I'd be very, very, very grateful.
Yeah, I'm certainly game to try. My goal for this whole project really was to understand which variables or what factors can predict whether a patient's going to progress to difficult to treat RA or not. So I developed a model in the BRASS cohort and validated it in CERTAIN. And how I went about that was I used a machine learning technique called random survival forests. I could have used Cox proportional hazards models. I could have gone the traditional route that we've tried and true that everybody knows. But Cox proportional hazards are about associations, how a variable is associated with hazards of an outcome. I was really wanting to get down into like individual level prediction, which is a slightly different question. What I like about random survival forests is that it's very robust to when you have a lot of variables that you want to parse through that may be correlated with each other or overlapping conceptually. I had over 40, I believe, when I started building this model from the BRASS cohort. And really, you can think of random survival forests as just an extension of survival methods where instead of building one model, I built 1,000, as many as you want to specify the model to build. 1,000 little mini prediction models, and each model, it's basically randomly sampling variables from the data set and picking the one that has the best split to find those patients with difficult to treat RA. And it's doing this repetitively, even in the model at each step, picking new variables, finding the best one, and then repeating this 1,000 times. And it's the power of the forest that kind of really starts to allow you to look at how did a particular variable do across all of these different models? How important was it to the prediction? Things that we don't typically look at when we're looking at more traditional methods.
Well, you did a wonderful job explaining it to me. I'm really grateful that you simplified this considerably. I want to go into the results a little bit. And there were 8 risk factors that you identified in this predictive model. Can you go over these factors, their relative importance, and how well they congeal together in order to make this model?
Yeah, so consistently across both the derivation, BRASS cohort, and the validation in certain patient-reported outcomes of that MD hack total score, the patient global score, fatigue and pain were the top predictors. Both data sets, different cohorts of subsets of RA patients, but these things were very important, and that was consistent and fairly strong. Additionally, C-reactive protein as a lab measure was also important, as well as a few other clinical factors, which kind of sorted in different orders of priority depending on which cohort I was looking at.
And overall, this model, I saw that there was a C index, right?
Mhm.
That took all these together. Were you satisfied with the C index? Can you help us parse a little bit through about that?
Yeah, absolutely. I mean, you can think of a C index as sort of similar conceptually to an AUC under a rock curve, in that it ranges from, I guess you could have 0 up to 1, but point 0.5 would represent a coin flip on whether this patient was at risk for difficult to treat RA or not, and then 1 would be perfect prediction. We had C index values that ranged from 0.62 to 0.64. So better than a coin flip, but definite room for improvement in the future if we can find more variables to add in that enhance the prediction.
Room for improvement. I always loved the puns with rheumatology. But these are really interesting. So there were the 8 factors, risk factors that you identified in the predictive model. Were these results surprising to you?
They probably shouldn't have been, but I think we knew from the prior literature and other studies that had used more traditional methods that rheumatoid factor positivity, higher disease activity, lower methotrexate use, and some comorbidities were important predictors of progressing to difficult to treat RA. And this is summarized across a couple different studies in the literature. They didn't have patient reported outcomes in there, but I knew that patients with difficult to treat RA do report greater pain and fatigue and all of those things. So I shouldn't have been surprised. But I think I was surprised that they were consistently the top predictors. And this is years before they developed. Most people in the cohort met the classification for difficult to treat RA.
And I think that's kind of the headline that,
Mhm.
these are predictors. So difficult to treat RA, they have all these factors. They look like that, but even before it becomes difficult to treat, they have these particular risk factors, including the ones that you had just mentioned. Were there things that you expected to be risk factors, but then just did not turn out to be risk factors?
Well, like I just mentioned, rheumatoid factor positivity was one that was seen in other studies, and comorbidities. Those did not float up as being important in my study. And I think some of that comes down to the difference in methodology. So, like I said earlier, with a Cox proportional hazards or that type of model that's looking at associations, and we've seen there's a lot of cases of where a variable will be strongly associated with an outcome, but when you use it to actually, does it have predictive value? Sometimes not so much. And that's kind of what I saw in applying this methodology.
Yeah. And, that's another part of the headline too, right? Associations are not necessarily predictive in the endpoints, right?
Right.
So this is super exciting. I'm very glad that you laid out the methodology and the results. I imagine that rheumatology fellows across the nation are picking up your paper and thinking of presenting it at their journal clubs. So let's make their lives just a little bit easier. What are some big strengths of your study?
Definitely the robustness of the design using a transparent, rigorous modeling approach, developing in one cohort and then testing it in entirely unseen data of new patients. I think the rich data sources that we had access to, all the different measures of disease activity, labs, characteristics of these patients is valuable and important, and the longitudinal aspect of follow-up. For BRASS, it was very lengthy follow-up. I think that's some of the key strengths there.
Yeah, absolutely. And I'm not an epidemiologist, but certainly I was impressed by the degree of accommodations that you took for the random forests using IBS and SHAP and all of that kind of stuff. I thought it was really neat, but I am not an epidemiologist. Can you explain to us on the flip side, what are some limitations of your study?
I did restrict this to a biologic experienced RA population, which is a subset of patients. I would be interested in the future to see if we could get even earlier in their disease course, perhaps when they're on a conventional DMARD. But for these purposes, I kind of restricted to biologic experience. There was some, of course, missingness that we had to deal with in the data, which is kind of par for the course when it comes with longitudinal data. And further validation work is definitely needed in other populations to see how this plays out.
And this kind of presages my next question as well. So, how do you think these results will empower future research into D2T RA and RA in general?
I think there's a couple different directions that this goes. As I mentioned, there's room for improvement in the model. So finding more clinical variables that might help with the prediction, which could range anything from more patient types of information on patient reported outcomes and maybe like trajectory patterns or changes to maybe some biomarkers that can be incorporated in. Secondly, I think this type of work really highlights that we can develop tools that can help personalize care. If you know years in advance that this is a patient that based on their pain reported profile, so to speak, that they're at high risk of becoming a difficult to treat RA patient, maybe that's an opportunity to follow them a little bit more closely, track their PROs, maybe that changes the therapeutic decisions. Wish I could say that my model could tell you what to do, but that's not what it was designed for. But just thinking broad terms in the future.
Maybe in the future there will be a model that will, be perfect in terms of describing it. But right now, this is what we have, and this is excellent in terms of the data that we have and all of the things that you mentioned in terms of your strengths. So I'm very curious in hearing your take. So you've mentioned about machine learning here. Your methodology is clearly robust, as we've talked about a little bit earlier, and you've compared it a little bit to the more classical means of analyzing large data sets. What do you think the future holds for using artificial intelligence in terms of research and clinical applications for RA prediction?
I think there is a role for AI, but I also think that we need to be a little bit careful about and thoughtful about where it adds value. So, one of the biggest drawbacks to the AI models that we care about in clinical space is the issue of correlation, not causation.
Right.
So, the strength of AI is pattern recognition. And we see this like really robustly playing out with the gains that AI has made in analyzing like imaging data, for example. So MRIs, functional MRIs, mammography, those types of things. But to think about how you bring pattern recognition to a clinical prediction model is much trickier. I think we always want to know, how the sausage is made, that kind of expression. We want to make sure we are understanding what factors are going into the model and where the clinical relevance is. And we need that clinical judgment piece to the table. So it's really about using AI to complement more traditional approaches. I don't think we can get away from the classic epi approach in clinical risk prediction, unfortunately, but AI is another tool. I think some applications are that it can help us identify new predictors that maybe we wouldn't have thought of, but then we have to make sure we understand why they're predictors and that there's clinical value there. I think it can help improve calibration, maybe in diverse populations, or it could help us to continuously update the risk prediction once we have a model and new data feeding into it. But whatever we do, we have to make sure we can explain it, we understand it, we can validate it, and we can use it in real clinical settings. And those are not easy things to solve.
So you're saying that we shouldn't be missing the forests from the trees and the trees from the
Exactly.
forests? Is that? So I think this is really very promising, of course, with the giant caveats that you're mentioning. I was also looking at some of your older publications, and as you mentioned in your biography, you've done a lot of different things in a lot of different fields. And I saw that earlier your work had been or has been on, I don't know if you're continuing to do it in the background, on sleep and insomnia.
Uh-huh.
You're an incredibly prolific author. So I wonder, how much sleep do you actually get? And what advice do you have for budding early researchers so they can get their citations and their winks in?
Well, sleep was something I focused on when I was doing my doctoral work back at the University of Minnesota. It was my personal area of interest for where I wanted my publications to go. But I was working with a very prolific group as an analyst, so I was had the pleasure of being on a lot of people's papers, and I think that's why I got so many publications so quickly. I once had an interview for a job that ultimately didn't end up working out, but the interviewer had said, "You're someone who plays in a lot of different people's sandboxes." Meaning that, I have my own research area, but as a methodologist, I'm helping other people all the time. And I think that experience is what I would say is so very important. At least I have found it to be so very important. You don't have to be a methodologist, but I think collaborating and being on a lot of different projects and papers really builds your skill set, your expertise, and your publication record very quickly. So, collaboration, that's my answer.
Maybe a future research direction could be is if this collaboration is an association or a predictor for future success.
There you go.
So, unfortunately, that is all the time that we have today. I'm very deeply grateful for your time, Misty. And in line with D2TRA, may the force be with you.
Thank you.
As we conclude this podcast, I would like to meditate a little bit on the diseases that we treat in our clinics and study in our labs. Rheumatoid arthritis is one condition that we've tamed for a large percentage of our patients, but that's not enough. Ensuring that we can develop effective treatments for those with difficult to treat RA is in the set of the next great challenges for our specialty. That way, we can ensure that D2TRA is an abbreviation that will belong rightfully in a galaxy far, far away. And as always, thank you for listening to this podcast. Vicky will be returning, and I believe this is the last podcast episode that I am recording as the guest host. But I've learned that, just like Star Wars, there's always a potential for further sequels and maybe even prequels. ACR Journals on Air is a podcast of the American College of Rheumatology. Please follow at ACR Rheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts. Thank you again.